So today we're going to be talking about immunotherapy, but not the therapy itself, but the neuro-ophthalmology of immunotherapy. And as you know, immunotherapy is very exciting treatment for cancer, and the Nobel Prize in Medicine was awarded for this concept. Under normal conditions, as you know, T cells, including cytotoxic and T helper cells, are interacting with antigen-presenting cells. And these antigen-presenting cells are in your immune system looking for trouble, looking for bacteria, looking for foreigners, trying to identify cells that are aberrant. And so when we have an interaction that occurs between the antigen-presenting cell and the T cell, that is an MHC complex, major histocompatibility complex mediated interaction that allows the T cell to recognize whether the antigen-presenting cell is self or not self. Are you me? And also, if that recognition handshake goes well, then presenting antigens that are not self, and that is also MHC, 1 versus 2, of course. And that process is really integrally important in general immunity. So whenever we're trying to deal with foreign antigens, the T cell is going to ask the antigen-presenting cell, are you me? And if you are me, do you have something that's not me? And that something that's not me is the antigen. The same process occurs with tumors. And that was the innovation of immunotherapy. So the T cell is making a contact, but not with an APC, but with a tumor cell. So the same process of recognition at the MHC. And if there's an interaction that says this is a tumor cell, the cytotoxic T cell can kill this tumor cell. But the tumor cells are smart, and they have developed ways to mask themselves. And so normally the interactions that occur, again, are immunologic, are the cytotoxic T cell lymphocyte-associated receptor, and also the programmed cell death receptor. So if the tumor can convince the T cell that it's not a tumor, it's not foreign, the T cell won't kill it. And that mechanism of evading immune surveillance of cancer is what is allowing this tumor to replicate. However, if we can block that interaction using a PD inhibitor or CTL inhibitor, then that is the basis of immunotherapy. So by blocking the masquerade of this tumor pretending to be a normal cell, we can allow our normal intrinsic adaptive and T cell mediated immunity to kill cancer. And that is immunotherapy. You might be saying, well, that's all well and good, Dr. Lee, but what does that have to do with neuro-ophthalmology? The reason it applies to neuro-ophthalmology is, remember, that's the same process that's going on over here. And so if we block the PD-1 or the CTL receptor, then we might unleash underlying inflammatory disease. And we might unleash cytotoxic T cell and T helper cell interactions with normal, healthy cells. The whole purpose of this process is to shield our cells from auto attack. And that self-tolerance requires that recognition site. And if we block it, then we might get into trouble. So normally Lee's rule of cancer is that if you have cancer and a neuro-ophthalmic problem, it's the cancer until proven otherwise. But the second most likely thing is a side effect of the treatment of the cancer. And normally, because the treatments of cancer are chemotherapies and radiation therapy, normally we only have to think about immunosuppression, infections, and radiation necrosis. But now that immunotherapy has been added to the list, we not only have to worry about radiation necrosis, secondary infections, and problems from the treatment, like chemotherapy, we have to worry about unleashing inflammatory disease. And so, any patient who's gone immunotherapy with a blocker at PD-1 like pembrolizumab or at CTL like ipilimumab, we have to know that what class of agent is this. So we can't just put they're on immunotherapy. You have to know what class it is. And if you have one of these inhibitors on board, then we're going to be worried about itis. Conjunctivitis, uveitis, posterior uveitis, optic neuritis, and endocrine thyroiditis, myasthenia gravis. So a whole host of things will be unleashed by blocking these receptors. And so the neuro-op of immunotherapy really boils down to recognizing that autoimmune disease, both on the afferent side, optic nerve, and on the efferent side, thyroid and myasthenia, can occur in patients who have cancer. So the new corollary to Lee's rule of cancer is, it could be the cancer, it could be the treatment of the cancer, it could be a side effect of the treatment of the cancer, and if it's immunotherapy, you should worry about immune disease, especially if it's the checkpoint inhibitor, PD-1, or CTL.